Okay, so now I want to talk about management of penetrating wounds. Now in our last lecture, we looked at when wounds were really, really big. These are the scary ones when you look at them. In this lecture, I want to look at when the wounds are small. But don't be deceived, because some of the most challenging injuries that you'll see are when the wound itself is very small. And I want you to remember that tissue injury, we talked about the body's reaction to tissue injury, but we also have to recognise that there are a number of different mechanisms by how tissues can be injured. So we have laceration, so this is a sharp division of those tissues. So it causes a very different pattern of injury to abrasions, where abrasions shear across the tissue, often removing tissue. We can also have crushing injuries. And crushing injuries are very challenging to identify because often the tissue will be damaged, but visually the tissues will look normal for probably some days until the injury becomes apparent. And this is very similar to thermal injuries. And that's the last case I showed you in that lecture, where the injury takes some days before it becomes very apparent. Chemical injuries are also not uncommon, and we can see combinations of these. So the way the tissue is injured can influence how it appears and how we assess that. So I think the important thing to note is when the wound is small, the injury to the tissues can still be very large. So what you see in a small wound may just be the tip of the iceberg. Now you're probably wondering, I have this picture here. This is where some Australians swim every single day of the year, even when the water temperature is near freezing. And they're a club of swimmers, they're called the Bondi Icebergs. So again, come to Australia, I dare you to swim in that in the middle of winter. It's not fun, but many people do this day in, day out. But tip of the iceberg is what I have in my mind when we see penetrating trauma. Small wound, injuries can be big. The consequence of missing injuries can be very severe, because the animals become very unwell if we don't identify the full extent of injuries. And so the three examples that I want to talk about today, which I hope are injuries that you see commonly, one would be dog bite injuries. Two would be pharyngeal stick injuries. So this is typically when an owner is playing with the dog, throwing the stick goes off, sticks in the ground, and the dog impales itself on the stick. These can prove to be quite challenging. And then other penetrating injuries. So when it comes to dog bite injuries are a bit like people in this room. They're all different. They've got their own personality. And we need to get to know this injury, because they can range from very minor. If a dog just nips at another dog, it might cause just very minor trauma. But the flip side of that is prolonged dog attacks can cause huge amounts of trauma. So I want to know from the owner, what was the size of the dog that attacked the other dog? Big dog on little dog interactions often don't end well for the little dog. I want to know how long that attack went for. Because if it was a fleeting instance, it's unlikely there is a severe amount of trauma. But if it was prolonged, particularly if the small dog was picked up and shaken, then I'm anticipating very severe injury in those cases. So they're the things that I want to know from the owner. When I look at the animal, one of the most important things is how it presents. Does it walk in happily to your hospital, or is it moribund? Is it collapsed and non-responsive? Now this is really important because it reflects the degree of tissue injury. And so I'm looking for demeanour, evidence of a more systemic response rather than a local response. That's important. To examine your patient fully, you may require analgesia. These dogs are sore, they might be trying to bite you. So don't forget providing pain relief before you examine them. And don't forget that bite wounds are often multiple. They could be in multiple parts of the body. And so I would recommend, to assess that wound fully, to clip really widely. You may even clip most of the dog, because you want to see bruising and you want to see the full extent of the injury. And so in this cat here and this dog, you can see the external wounds are not big, but until you clip away all that hair, you don't have a chance to see where the attack was and the extent of injury. So clip them widely, get to know the injury, and find out how much trauma has occurred. Now, tissue damage is a proportional thing. So I showed you this picture of the cut pad. Now, when this pad is injured and the tissue is injured, it releases lots of inflammatory mediators. Now, these inflammatory mediators are really good. They're part of that wound healing process that we spoke of. And so we get things like procoagulants to stop the bleeding. We get vasodilation, increased vascular permeability to let all those white cells in. And pain. We get sensitization to pain, and this stops the animal using the leg. So all of these inflammatory mediators are part of the wound healing process. On a local scale, they're really good. So this is what we want for wound healing. The problem is if we have a more traumatic distal limb injury like this. So this is a traumatic amputation where the cat has lost its distal limb. In this case here, we get the same response. We get inflammatory mediators, but we get a whole lot more. So now they don't just act locally, but they're now going to affect the entire patient. So this is important to recognise. We can see those local effects, which are good, but then you can see a systemic effect. So essentially a systemic inflammatory response. What that means, and this is more Ellie's area, so I'm talking out of school here, but this is a surgeon's diagram to trauma. It's very simple. It says all those things that are good on the local level, when they go outside the local level, they're not so good, because that increased vascular permeability, the vasodilation, all of this will lead to poor blood pressure, poor perfusion, and multi-organ dysfunction. So recognising where this animal is on the scale of trauma is important, and how the animal presents is the first key. So if we think of tissue damage as a whole body tissue injury, the cut pad sits down here. Only a small amount of injury, small amount of inflammatory mediators. This is likely to be self-resolving. So at the other end of the scale, we can see animals that have so much trauma that they won't survive. And this is termed the critical level of trauma. And so there are some patients that have so much tissue injury, no matter what you do, you cannot bring those animals back from that state. So this concept here of tissue damage being a sliding scale is important. So again, that cut pad is likely, even if you didn't treat it, is likely still to go on and heal. We said the body knows what it wants to do. It might take a longer time, it may not heal perfectly, but it's likely to heal. We've got this end of the scale. If we do nothing, the amount of trauma is likely to increase because of infection, further damage to those tissues, and this animal, left untreated, is likely to progress past that critical level of trauma and not survive. And so if we saw a case like this, I think we'd all recognise we have to take some action, and that action is likely to be to amputate that damaged portion of the limb. But as a surgeon, remembering we create more trauma. So we're putting additional trauma on an already traumatised patient. And that's really important when it comes to emergency surgery, because to take that limb off causes more tissue damage. Every bit of trauma that we inflict here brings us closer to that critical level of trauma. So your actions in these cases are magnified. Everything counts. If you take a healthy 6-month-old animal and you dissect them, then again, that animal is perfectly healthy. You could do a terrible job. The animal probably will still survive. But if you're not doing everything right in these critical patients, then again, you take them much closer to that critical level of trauma where they won't come back. And so when we talk about surgical technique, about doing the best job, again, small details matter in these cases. So in emergency surgery, planning, your technique, your tissue handling, all become particularly important. And what's important, I think, is to do as much as you need to do, but not too much. So what are those cases where we should really worry? So we've said if they're prolonged attacks, they're of concern. The other thing that concerns me is if they're over the abdomen, the thorax, or the neck, particularly if it was a big dog on a little dog or a cat. So the reason for this is these are the most vulnerable areas of the body, and it's very hard to assess them. So with a big open wound, you can easily have a look and you can see what tissues are damaged. When we have puncturing wounds over the abdomen or the chest, it's much harder to tell how much injury has occurred. And so when we're assessing these deeper structures, it's all about what lies beneath. what we can see with puncture wounds is often just this. So if we have a little explore, the animal presents with a wound, you probe, you examine within that wound, really you can only see a very limited amount. To see everything else, we're going to rely on some form of diagnostic imaging or surgical exploration. And again, if we don't action these appropriately, these animals could develop more tissue trauma if they've had injuries that we haven't identified. So sometimes we'll do imaging first, and that will help us make our decision to go to surgery. And there are other cases where we will go straight to surgery. And I'll talk about how we help make those decisions. So I want to talk now about wounds to the neck. And this is probably the only publication that looks at bite wounds over the neck. But it gives us an idea of how much trauma can occur, particularly when an animal is pinned down and shaken. So in this case series, about 17% of the dogs had damage to the trachea or other vital structures. I'll talk about how we explore this area when we talk about pharyngeal stick injuries, but if you're unsure, if you don't have advanced imaging like a CT scan where we'll be able to see the extent of trauma, then exploring this area is a reasonable option to look at what damage has been done and to provide drainage for that anticipated debridement phase which will always occur. Here's another instance here of a bite around the ear. Now, the dog presented with a small bite wound just by the ear, but the veterinarian didn't have the opportunity to look down that ear. If they looked down that ear, they would have noticed that the canal was torn. So for any bite wounds around the base of the ear, I always do an otoscopic exam and look down the ear. Because in this case, what happened is there was contamination of that wound because of the rupture and the tear to the canal. Tissue debrides as it should do, but it had nowhere to go. So it formed a very large abscess and we saw ongoing tissue injury. So this was the end result. And so missed injuries can mean much more damage to the patient. Here, that natural healing process has led to large abscess formation, which then required additional surgery. This dog had a total ear canal ablation and reconstruction. And again, here you can see the use of drainage. So we can perform closure if we provide drainage, and this was deep in that middle ear. But you can see a good result, again, if we support the body healing itself. But it's about recognising that we need to fully assess the extent of damage so we don't miss inadvertent injury to those tissues. Here's another little case here. This is a beautiful little dog, very sweet, attacked by a very large dog here. And we can see here it's just a small wound on the chest. Now, if this was a history of just one quick bite and the dog was really bright and well, no problems with respiration, perhaps that's only skin deep. But let's watch this dog breathe here. So you're all probably thinking there's concern about viability of this chest wall and its structural integrity. So what would we do next? So we might do some imaging, try and find out what's happening a little bit deeper in. And here we can see we've got consolidation of those lobes on that left. We've got some collapse. This is an indication to head to surgery. I'll talk about the parameters that I use to decide whether to go to surgery. What you can see when we incise through this, just the skin, that bite wound goes right through those intercostal muscles. It's a little unnerving when you cut through the skin and you can see into the thoracic cavity, but that's what happened in this case. Once we open it up a bit further, we're going to explore to see where the tooth ended up and how much damage has occurred. Here we can see saline being placed into the thorax, and this bite wound resulted in injury to the lung and leakage of air from the lung. Left untreated, this animal would develop a pneumothorax, and certainly that tissue injury is likely to be more severe.
So there's multiple areas.
And whenever we close these wounds, we said rarely do we primarily close traumatic wounds, but one exception is when it goes into a body cavity. We can't leave the thorax open to let that heal by second intention, no matter how good your wound dressing is. And so we place two drains. One goes into the thorax to evacuate any additional air. The other one goes into the subcutaneous space. And the drains that I like to use in the subcutaneous space are these Jackson Pratt drains. They're a simple tube drain, and they're attached to a grenade which provides negative pressure and it collects the fluid. Relatively inexpensive, but we tend to use these in most cases over the passive drains, like the Penrose drain. So these active drains are not gravity dependent and they reduce the risk of infection. Now, I mentioned this little dog, you can see how sweet he is. Sometimes our patients are really appreciative of the work we do. Here he is here. He loved me, that little dog. All my hard work, he tried to take my face off. So, there is some literature around to support our decision-making process, and when I see bite wounds over the abdomen, here are some indications that might suggest that surgical exploration is required to decide on the extent of injury and to potentially stop any leakage of air from damaged lung. Now, when I see a big dog, little dog interaction over the abdominal cavity, this is one case where I don't image. There's no harm in imaging, but I'm going to be recommending a surgical exploration, mainly because all of the imaging modalities that we have available to us cannot always identify the degree of injury that's occurred within the abdominal cavity. And so, if I see big dog on little dog attacks, crushing and bruising over the abdominal cavity, I will always recommend surgery. I don't go through any wounds because it's very hard to explore the abdomen. We do the ventral midline approach like any other exploratory laparotomy. Here we can see a dog here, no puncture wounds. The skin isn't damaged, but you can see multiple bites over that abdominal cavity. And what we found was multiple areas of damage to the wall of the abdominal cavity that needed reconstruction to avoid multiple traumatic herniations occurring. Fortunately, no other tissue was damaged, but a common one we see is crushing injury to the intestines, and that can really only be seen at surgery. Even ultrasound CT cannot show us that crushing injury where we've had compromise to the blood supply and that tissue will take some days to die. It's very difficult to see. So this is an example here of just a tear in the mesentery, but this will cause compromise to the blood supply to that area of intestine, and left untreated, that would become necrotic, and again the trauma would increase. So I always go ventral midline approach, full exploratory. I'm particularly looking damage to the body wall, but also the gastrointestinal tract, but we want to check all structures, including the urinary tract and reproductive tracts. Now, when I have contamination of the abdominal cavity, we talked about lavage. Here I do use sterile saline. I wouldn't use tap water in this case if we go into the body cavity, but large volumes, 200 to 300 mils per kilo. So in large dogs, this can be litres and litres. So you will need some suction. And the way I approach these is I repair the abdominal wall from the inside, and then I close the abdominal cavity and I go to the external wound and treat that as a separate wound once you've sealed off the abdominal cavity. Abdominal cavity first, then the external wound. That may require some repositioning. I don't know if any of you have seen this movie. This is about a man who climbs 1 kilometre vertical wall, El Capitan in Yosemite, without a rope. It's called Free Solo. His name is Alex, and he climbs for fun in this way. And what he says when people say to him, "This is so risky," he tells them, "The risk is not high. The chances of me falling are very small. What's high is the consequence. Essentially, if he falls, he dies." And so he separates that. The risk is the possibility of something happening. The consequence is what you stand to lose. And I say this to owners. We may go into this abdominal cavity. We may find there is no injury to those tissues. But the consequence, if we wait 2 to 3 days and there is a rupture of the gastrointestinal tract, the consequence is high. Now we have a septic abdomen. But if you are going to do this surgery, you need to be very efficient, because remembering, it's additional surgical trauma on an already traumatized patient. So we don't take it lightly, but because of the high consequence, then again, surgery is something I would always recommend. Okay, we're going to do a little tour again of Australia. This is Queensland. This is Magnetic Island off Townsville. Has some of the most beautiful beaches I've seen here. You can see just idyllic. And it sits just off Townsville And there is a veterinary school in Townsville. So if you want to go on a work trip and visit one of the universities in Australia, it's located in this beautiful part of the world. This is my son down here by the water's edge. He's looking at the rock wallabies that sit all around this island. And you can wander the island and see these koalas just sitting in the trees so close to where you walk. And when you look at the beautiful Australian wildlife, I know you probably have a couple of questions. One might be, do we ever operate on these? And yes, the answer is these animals do get hit by cars. Here we're doing a fracture repair. So yes, you can operate on Australian wildlife. The other thing that I'm sure you're wondering is there a big koala in Australia? And the answer, of course, is yes. Remembering Australia is a home of big things. It's not the most attractive koala I've ever seen, but again, Australia has to have something big of everything, including the koala. Okay, so we've got 15 minutes to go. I want to talk about pharyngeal stick injuries. These are hard for a couple of reasons. It's hard because it's hard to look in the mouth. These animals need to be anaesthetised for you to examine them. But again, what you see is tip of the iceberg. Here we can see probably the best case scenario. This is a partial thickness injury to the soft palate. And in this case here, we probably don't need to do a whole lot more. But sometimes we see cases like this, where it goes all the way through the soft palate. And in this case here, the only way to know what's happening behind would be to do advanced imaging, like a CT scan. Now, the nice thing with these is there's not too much in terms of where that stick can go. It hits the base of the skull. We've seen injuries to that skull and fractures associated, but generally they stop about there. They're hard to get to. You've got to split that soft palate to explore, so generally we would use advanced imaging. The ones that don't go up and hit the roof of the mouth, that head down the throat, so on either side of the larynx, these are the ones that I worry about because there's nothing to stop it. These can go a long way down the neck if they're in this location. So beside the larynx is more concerning. If they're in the soft palate, that's not too bad. So the imaging that is available, if you have CT, this is ideal. If you don't, the thoracic radiographs and cervical radiographs are a good starting point. If I see gas all the way down the neck, then I'm making the assumption that stick is headed all the way down that neck. I'm thinking here I have to explore. I'm going to take you through how you explore this area to find that tract. So this is an example here. Often they're sticks. You won't see them on the radiographs, but can everyone see all that gas within the tissue planes of the neck where there should be none? If you see this, this warrants either additional imaging or additional surgery. In this case, we went for a CT scan, and you can all see this very large straight stick running obliquely around this neck. This was a German Shepherd dog. It walked in like nothing was wrong. So the owners didn't even realise this had happened. If you want to explore this region, if you think of the neck like another body cavity, it has paired muscles on the top. This might be similar to your abdominal muscles. When we go into the abdomen, we split right down the midline and then we can explore that abdomen. The neck is a bit the same. There's two paired muscles, the sternohyoids here, and you can split them. You can actually, once you cut through the skin and the platysma muscle, just run your finger down these paired muscles and you'll see the divide between them. Just split them like you would enter the cavity and you'll see the trachea sitting just below. On either side will be the vagosympathetic trunks here and the esophagus. This is where the sticks will go. So you're already into that cavity. You need to check on either side of that larynx. If you put something underneath their neck here, that brings it much closer to you as the surgeon, so you don't have a deep dark hole. So something beneath their neck when we position them. And again, we just split through these muscles. What sits at the floor of that is the epaxial muscles. So there's a floor to it as well, like the abdominal cavity. This is what you see when you go into that space. You can see that stick. It's nice if you have imaging so you know what you're looking for. Here we can see the stick. In this case, it was so big I couldn't get it out. I had to get a saw and cut that in two. So I had no way of getting it out. And this is what we retrieved. So this was a very newsworthy story, and because of the size of that stick. But remembering, when you go into these cases, we know there's contamination. We know there's tissue damage. So we know the animal will go through the debridement phase. You lavage and debride, take the stick out, the foreign material, but you've got to provide drainage. Here you see that Jackson Pratt drain that I spoke about earlier, closed suction drain, important to take out the remaining and residual fluid that we know will accumulate. And again, I said newsworthy. This is the only time I've been on the front page of any magazine or newspaper, but they like that. This is the worst case scenario, and these are the cases that are associated with the poorest prognosis. These are tears to the esophagus. These are really challenging cases. My advice here is you have to open them widely. You need to be able to visualise the esophagus well. You can't treat this like an open wound, so you need to close it. But because of the location, it's very difficult to access. So these are challenging. I will often warn the owners of the high risk of dehiscence. When we've seen these, there are more cases that we re-operate on than get healed with a single surgery. Simply because of the nature of the injury, there's often a crush component. These are really challenging to suture. So prepare yourself, take your time. I use stay sutures to try and manipulate that, and I just do full thickness bites through the esophagus. It's very thick and robust and good to suture, but it's hard to visualise. 2-year-old Kelpie here, can you see the gas in the cervical planes here? So again, this would cue us for more advanced imaging. Again, CT, again, another stick. Always surprising how big they can be. This is surgery. Again, there's a trachea here. This is a colleague of mine. I don't tend to use Gelpie retractors because of the risk of damage to those structures within the neck. So I tend to use Army-Navy retractors. They're a bit gentler, so they're the flat blades. But in this case, we've got a Gelpie, and you can see that stick there sitting just beside the trachea and the esophagus. If you're unsure what the esophagus is, pass a stomach tube down. Then you can see if there's an esophageal tear. You can also see where it is so you don't damage it. And here we can see a little video here of the stick coming out. So in our practice, we would use advanced imaging all the time with these because it's much more likely to tell you the size and shape. If you don't have advanced imaging, then you can still explore, and often you will see the tract running down there in that neck. Here's a 7-year-old border collie. It had a stick injury and developed a recurrent abscess. Why is there a recurrent abscess? Because the body can't get through the debridement phase. We're stuck in the debridement phase. So what could cause that? Again, we might have resistant bacteria, we might have necrotic tissue, we might have foreign material. With a stick injury, the most common thing is residual material. Often the owners will pull out the stick sometimes if it's sticking out of the dog's throat. But what can be left behind is just the smallest fragments here. Here we're seeing something that measures just a couple of, or 1 centimetre or 7 millimetres by 1 millimetre. But we could see this is foreign material. This was ultrasound. We also did a CT. And here's an intraoperative image. We can see often the tract that is left, so you can find the abscess. And then now, this is not as impressive as the other videos, but I'm going to show you, this is all it takes to cause recurrent infections. So you can see there's that small splinter of stick that was residual in the neck. And so many times we can see animals that go through 2, 3, 4 surgeries until that's removed, because that will continue to reform. So advanced imaging is very, very useful in these situations. So in the remaining few minutes here, I want to talk about some other penetrating injuries. This is a dog that tried to jump over a fence to chase a cat. Unfortunately, the fence was one of those fancy fences with spikes on the top, the fleur-de-lis, and it caught itself on that. So here we have a penetrating injury into the abdominal cavity. We said we won't suture traumatic wounds except if they go into a body cavity. So again, let's follow those same principles of penetrating wounds. Tip of the iceberg, you can see the initial wound might not look too bad, but when you explore, you can see I'm holding intestines in my hand on presentation. Never a good thing. Prognosis is still very good, but when we clip and clean this wound, we can see penetrating injury. I can't tell how much injury has occurred within that, so we're going to go in and explore. Any penetrating injury into the abdominal cavity, we will go in surgically, and we're going to go in, as we said, through the ventral midline approach. So we make a new incision, ventral midline, and we explore. Here we can see no damage to any vital structures. Very lucky dog. There was a fraction of the transverse processes, so the dog had impaled itself with quite some force, and then we close it. We close the abdominal cavity, and from where we explored, and we close the traumatic wound. So we have to seal off that abdominal cavity. We know a fusion will continue, so we place a drain. Again, Jackson Pratt drain, closed suction is ideal. Here we can see after surgery, what we have is a surgical incision and the drain coming out. 10 days after surgery, animal returns. Suture removal has made a really pleasant recovery. So, if you see these penetrating wounds into the abdominal cavity, if you get in there early, then particularly within that first 6-hour period, then you've got a contaminated wound and not an infected wound. You can decontaminate, lavage, assess that, provide drainage, and the prognosis is generally still quite favourable. Yes, so we went through, we had to just resect out all the dead tissue, and then we made a separate incision, but the skin incision was large enough. We didn't have to make a separate skin incision. This is the dog that impaled itself on the stick. Again, tip of the iceberg. We don't know how far that's gone. When we CT it, you can see it's actually gone through the lung and it's gone through the liver. So this guides us. We need to make an approach to both cavities. Lavage both cavities, drain both cavities. Again, this dog did very well. About 10 days was running around like nothing happened. So initially they can be quite confronting, but again, following those principles that we spoke of, again, assessing how much damage has occurred, and then removing, decontaminating those body cavities. But the important thing in this case is don't remove any penetrating foreign body that is in the cavity until you know what's involved or until you're in surgery. Because if you don't have advanced imaging, you would prep widely and then you can explore both cavities and you would get the same result, but you need to be prepared. This is actually a very tragic case. This is a stab injury to a dog. So I was walking in the park and someone who was mentally unstable stabbed this dog. Small wound, unsure of what damage was done. We recommend going to surgery in this case because of the risk as if we miss any injury. And I just use this to show you the example of how what we see is tip of the iceberg. Here we can see within the abdominal cavity, this is the injury through the wall, and then it had gone into the stomach. And so, again, any penetrating injury into the abdominal cavity, to me, you don't always have to image before you say I'm going to surgery, because the risk of missing an injury could be catastrophic for these patients. And this is what I saw just a week ago, a lame dog, small injury on the limb, but we could feel the dog was very painful right in this area, almost non-weight bearing lame. This is a nice example to show you, again, penetrating injuries, small wound, but we can have more serious injuries. So this is a big thorn that was running along. So notice how I don't follow the thorn's direction, because in the limb you always want to orientate your incisions proximo-distal, because all the vital structures run in that direction. So that's why we've made a vertical incision, and here we can see what we've removed here. This is the thorn, but look at that tip, it fractured off. So you want to explore widely to make sure you get it all. Okay, so the take-home messages. Again, it's easy to miss injuries in an emergency setting. Follows Ellie's rules about re-evaluating all the time. Be careful of those injuries over the neck, over the thorax and abdomen. And remembering that the principles of surgery stay the same as large open wounds, the differences are that we might rely more heavily on imaging with these penetrating injuries because what we see is just tip of the iceberg, and that you need a strategy for drainage. So if there's not going to be ongoing natural drainage, then consider those Jackson Pratt drains for draining out those body cavities. Alright, and once again, this is my team and their dogs. And you'll see my silver little dog up there as well. So again, acknowledging all the help. Thank you very much.